All right, good morning, everyone. Today we're going to be covering the last two learning plans of the class. And we're going to be covering learning plans 14 and 15. So we're going to start off with the reproductive system, finish off with the urinary system. So both systems aren't extremely involved, not extremely complicated. What we're going to do when we cover the reproductive system, we're going to start off talking about the male reproductive system, then we'll finish off with the female, and then we'll move on to the urinary system. Let's see here. Okay, so first we're going to look at is the general makeup and anatomy of the male reproductive system. What we're looking at, we're going to start with here is where everything begins, and it's right here in a sac called the scrotum. And it's basically a combination of skin, superficial fascia, and it houses the sperm producing and sperm storing organs. So the reason why the testes, which are located inside the scrotum and the epididymis, the reason why they reside where they do is because they're not viable. The sperm aren't viable at body temperature. It's actually not ideal for their survival. So the body naturally carries them outside of the internal environment of the body to keep them about 3 degrees below the core body temperature. Now, the temperature obviously fluctuates within the body. Sometimes it goes up, sometimes it goes down, sometimes the external temperatures vary and change. So there's a mechanism built into the scrotum to keep the scrotum at a constant temperature, a relatively constant temperature. And so there's a muscle that is called the cremaster muscle, and the cremaster muscle will contract or relax, and when it contracts, then the testes will move superiorly. When it relaxes, then they'll move inferiorly. And this is all designed to keep the testes at a relatively constant temperature. You can also see we have some vascular structures here that are going to provide the testes and the associated structures with oxygen and nutrients. So we have a testicular artery, we have a testicular vein, but we also have the nerve endings as well. All right, looking at the testes, they are what we call the primary reproductive organ of the male, and they produce both the sperm and also the testosterone, which support the development of the sperm. And if you look at the testes, really what you see is the testes are basically consisting of a network of tubes. So you have tubes which merge to form other tubes, which merge to form others, which then eventually merge to form one single tube, which will leave the testes, and that tube is called the ductus or the vas deferens. So within, I should say, housing everything and keeping everything kind of contained, we have something called the outer tunica vaginalis, which you see here is like this outer region here. And then we have the inner region, which is called the tunica albuginea, which you see right here. And then you can see that the testes are divided up into smaller sections called lobules right here. 1, 2, 3. So there's several different lobules here. And these are networks of tubes. And this is where the sperm are going to develop and mature. And then once they have developed and they mature, then they're going to make their way to the next area, which is the rete testes, and then the rete testes will lead to the epididymis, which you see here as this structure right here. So this structure right here is the epididymis. Again, you can see that though the epididymis is made up of these what we call sort of like ducts, really. So those efferent ductals will lead to a what we call a straight. I'm sorry, not a straight tubule, the body of the epididymis, or make up the body of the epididymis, eventually to the duct of the epididymis, which then will lead to the vas deferens, which you talked about before. Okay, so looking at these tubules, which make up a majority of the testes, what we're looking at here is the tube itself. But we're looking at cross section. So imagine if you take a drinking straw or something, and you cut it, and then you look at it from the end. So here we have the lumen, which is the opening in the middle of that tube, and surrounding that lumen are actually the sperm cells. These are all what you see here. All these nuclei here. These are the sperm cells that are developing and maturing. And then we have supportive structures around the sperm cells to help aid in their development and growth. Okay, so going back here, let's kind of clear this off so we can just kind of go through what we're looking at here. Okay, so we've got the seminiferous tubules, in each lobule they converge into the straight tubule. So here are the straight tubules right here. Then they'll lead to the rete testes, as it says here, and then they'll pass through the efferent ductals into the epididymis, in which they'll be stored. So basically the sperm are stored in here when they're ready to go. And then during the ejaculation, that's when the sperm will make their way through and exit through the ductus or the vas deferens and make their way toward the urethra. Okay, something we didn't talk about in this picture before were the what we call the interstitial endocrine cells. They call them Leydig cells, and they produce the testosterone. So you can see that between the seminiferous tubules, you've got almost like these triangular shaped structures, and in there, that's where you're going to see those interstitial cells that are going to be producing the testosterone. Okay, let me see here what we're going with this picture here. Okay, well, that's not what I wanted to see. Okay, we're going to jump around a little bit because obviously this is not entirely accurate here as far as where we're going with the slides. Okay, so anyway, moving on to page number 2, letter D, the penis. The penis is the copulatory organ, and with reproductive function, it's designed to deliver sperm into the female reproductive tract. But the male and female reproductive system is a little different in that the male reproductive organ, the penis, is also designed or also designated for urinary function, whereas in the females, you have 2 separate structures, one for reproductive function and one for urinary function. You can see that the penis is attached at what we call the root as a free body that extends in an enlarged tip, which we call the glans penis. So this is the root where it's anchored to the body, and then we have the tip, which is called the glans penis. Now this is homologous to a structure in the female reproductive system. It's not going to work now. Called the clitoris. So the 2 structures are essentially equivalent. So in a developing fetus, if it's a female, the glans will develop into the clitoris. If it's a male, it'll develop into the penis. Covering the glans penis is what we call the foreskin or the prepuce. Now, depending on several different considerations, parental preference, or maybe religious reasons, the foreskin may or may not be removed. So if it's removed, it's a process called circumcision. And in circumcision, what they'll do is they will remove the distal part of the foreskin, and then the glans penis then will be exposed, and you can see the glans penis. If the foreskin remains, if it remains intact, it's not removed, there's no circumcision, then the glans penis will remain covered. So if you look at a cross section of the penis, you're going to see that there are actually 3 different chambers here. They call it the monkey face. So what we see here are these 2 chambers here, and these 2 chambers are called the corpora cavernosa together. Otherwise, you call it the corpus cavernosum, each one of them, corpus cavernosum, or the corpora cavernosa collectively. And within the corpora cavernosa, you see some deep arteries, and these deep arteries bring blood into the region. During sexual stimulation, the deep arteries will fill with blood. They'll engorge this area here, the corpora cavernosa, with blood, allowing the penis to assume an erect position or erect configuration, whatever you want to call it. All right, so then we also have this one here, which is another corpora. It's the corpus spongiosum, and the corpus spongiosum, in the middle of that is the urethra. Allows for the passage of sperm or urine, depending on what function is being used. So what we see here is that the male reproductive system is basically a system of ducts a system of tubes. So one set of tubes that leads to another set of tubes, which leads to another set of tubes, and so forth. And so we start here in the testes, and we have the lobules, the seminiferous tubules. They lead to the epididymis. Then the epididymis will then lead to this structure here, which is called the vas deferens, or the ductus deferens. You're going to see that the ductus deferens are going to come around, and they're actually going to pass over and anterior to the bladder. Here you'll see that the vas deferens will kind of dilate to a larger region. That's called the ampulla of the ductus deferens. Now we've got some associated structures that are found near or around the ductus deferens and the duct mechanism. One of the ones that we see here is the seminal vesicle, and we'll talk about that in a little bit. We've also got this structure here. Once the two ductus deferens merge in what we call the ejaculatory duct region, now we have the urethra. So once they become unified, now we have the urethra. The part of the urethra that's found in the area of this gland here is called the prostatic urethra. This is the prostate gland. So it's kind of like a donut in that there's a hole in the middle of the prostate, and then the urethra passes through that. That's why as the prostate becomes enlarged, which it does on average for most men as they age, you can picture that the opening in that donut gets smaller and smaller, which then closes off the prostatic urethra. So that's why it's not atypical for older men to have difficulty urinating, or it takes them a long time to urinate because the opening through which the urine passes from the bladder into the urethra is narrowed. Once we get past the prostate gland, we have two other glands, one on each side. They're called the Cowper's glands, or we also call them the bulbourethral glands. We'll talk about those in a little bit. They're going to also secrete their own secretions. And then finally we have the urethra, which is going to carry, for reproductive function, the sperm out through the end of the reproductive tract. Okay, so some of the accessory glands of the male reproductive system, we talked about them already. So we have the seminal glands, or the seminal vesicles, whatever you want to call them. They have an alkaline secretion, and this alkaline secretion is about 70% of the semen, which is the mixture of the sperm and the other secretions coming from the male reproductive tract. What we see in the seminal glands as a secretion is fructose, ascorbic acid, and also a coagulating enzyme and prostaglandins. These are designed to help support the sperm and help keep them alive, and also give them what they need to perform the function. So once the sperm make it to their destination, which is the female reproductive tract, the sperm need to travel through the female reproductive tract to get to where they want to, which is the unfertilized egg. So we see that fructose is there. Fructose can be converted into ATP to give the sperm energy to swim. We also have the ascorbic acid, which will be converted into citric acid, which then can be used to create ATP. So we see that as well. We have a coagulating enzyme. And the reason why there's a coagulating enzyme that is secreted with the sperm is because when the sperm make their way into the female reproductive tract, the first place that they end up is in the vagina, which is an acidic environment. It's antimicrobial. It's not sperm friendly. And so when the sperm get ejaculated into that region, if they just started swimming through the female reproductive tract at that time, a lot of them will get killed off. So what happens is they get released into the female reproductive tract with this coagulating enzyme, which kind of keeps the sperm from moving too much, and then kind of allows the environment to sort of neutralize, and then after a while, then the sperm can start making their way along the way. So, prostate gland, it's a milky, slightly acidic fluid, contains citrate. That's for the citric acid cycle, as we mentioned before, enzymes, a prostate-specific antigen, and it plays a role in sperm activation. So this kind of gets the sperm active and get them going and tell them that it's time to start moving. We also have the bulbourethral glands. Most of what they secrete is like a mucus-like secretion that is going to neutralize any acid that might be in the urethra, any residual urine that may be in the urethra to help neutralize that, and also create a slipperier path and a slipperier surface for the sperm to pass along, so they don't get too nicked up or banged up along the way. Okay, so that's pretty much the anatomy of the male reproductive system. It's not entirely complicated. It's basically this network of ducts. So let's just review that quickly, and then we'll move on to the physiology of the male reproductive tract. Okay, so first thing we start off with are the testes. So we have the testes here. Oops. Well, there's your first term if you want to grab that before I go back and switch it back. My intention was to activate the marker, but that didn't work. Okay. So we've got the testes. Okay, inside the testes, what do we have inside the testes? What's inside the testes?
Lobules.
Lobules of what? You're right, they're lobules, but what makes up the lobule?
Sperm cells.
What are the sperm cells located in? You're correct. But what are they located in?
Seminiferous tubule.
There you go, the seminiferous tubules. So we got the seminiferous tubules, which are contained in lobules. Yep, you got it. Okay, so we've got the seminiferous tubules here. Okay, and then those seminiferous tubules are divided into lobules, right? So you have the seminiferous tubules, lobules. Okay, and then the seminiferous tubules will lead to what? What's the next set of tubes? Yeah, the straight tubule. We have these straight tubules, which then lead to what?
The red testes.
Yeah, the rete testes, right. The rete testes, yep. Okay, so the rete testes then will lead to what?
Efferent ductal.
Yep, the efferent ductal, yep. And then the efferent ductal is going to lead to what?
The tail of the epidermis.
The epididymis, right. So now we've got this network of tubules here. They say it's comma shaped. So we've got this network of tubules here. And this is called the epididymis.
ID.
Is it DID? Thank you.
Y.
YMIS. Or is it
Yep.
US?
IS.
Yes, okay, epididymis. Thank you. Couldn't remember where the Y was. All right, so we got the epididymis, which then leads to a tube. What's that tube called?
The
Ductus.
ductus.
Or the vas deferens. Yep. So, whenever you have the suffix ectomy, that means to remove. You get an appendectomy, you get the appendix removed. Cholecystectomy, get your gallbladder removed. So a vasectomy means that you are removing some of the vas deferens, cutting it, tying it off. So that's what a vasectomy is. You're actually taking the ductus deferens and you're cutting the ductus deferens in an attempt to prevent the male from ejaculating the sperm into the female reproductive tract. So that's what a vasectomy is. Okay, so we had the testes, and then from that we had the vas deferens. Okay, we've got the bladder here. Okay, so the vas deferens is going to make its way up here into the enlarged area of the vas deferens. What's that called, this enlarged area right here?
The what? Urinary bladder?
This is the urinary bladder here, but the vas deferens will enlarge. Yep, the ampulla. So that's the ampulla. Okay. And then they'll come together, they'll merge, and then there'll be a gland right here, the donut-shaped gland. So before that, we have a gland that's going to produce a secretion that's about 70% of the semen. What's this called?
No gland?
Yep, the seminal gland. Or we call it the seminal vesicle. Okay. And then we have this gland here, which is what? The donut-shaped gland, which is the
Prostate.
prostate. And then below the prostate, we have two small glands here. And what are those called?
Bulbourethral gland and duct.
Yep. The bulbourethral gland. Also called the Cowper's. If you hear the Cowper's glands, same thing. All right. Nicely done. Okay, so next thing we're going to talk about is the physiology of the male reproductive system. Let's first talk about the male sexual response, then we'll talk about how the sperm develops. So the male sexual response, remember the blood is going to enter those corpora cavernosa, and that's going to be done because the parasympathetic division of the autonomic nervous system becomes active, causes the release of nitric oxide, which causes the dilation of those arterioles, and then that reduces blood flow out of the penis, so you kind of get a backup of the blood, which allows for the erection to be maintained. So then the next step in the male sexual response is the ejaculation. So you propel the semen from the male duct system. And so what I always tell people is that the male sexual response comes down to two things. We have the parasympathetic and then the sympathetic. And the parasympathetic is the erection and reaching the end of the board, that's why. And then this is ejaculation. All right. So it's kind of hard to see. Look on the screen, the other screen, probably easier to see. But easy way to remember this, P and S. And I didn't come up with this. I was taught this. Point and shoot, right? So the parasympathetic is the point, it's the erection, and then the sympathetic is the shoot, the ejaculation. See, you'll never forget it now. Don't tell your kids. All right. All right. So one of the things that we're going to talk about in advanced A&P, for those of you who are taking advanced A&P, is meiosis versus mitosis. Meiosis is cell division in which you start with one cell and you get two identical daughter cells. Okay, that's mitosis. That's cell division, growing in size, growing in number. But we also have meiosis, which is the cell division that is for reproductive purposes. So you start off with one parent cell and you end up with 1, 2, 3, 4 daughter cells with half the normal number of chromosomes. And the reason why you only have half the number of chromosomes is because you're going to be taking 23 chromosomes from the father and 23 chromosomes from the mother, combining them to get a full set of 46 chromosomes for the new organism, the new person. So you want these haploid cells, only 23 chromosomes each, so you have to divide it off. So what we're going to see in the sperm cells, and we're going to see a slightly different version of this in the females, is that we start off with a parent cell here. This is called the spermatogonium. It's the stem cell. And that stem cell is going to double its chromosomes, and then it's going to divide. Okay? One is going to stay here. And then the other one is going to become what we call a type B daughter cell. Now this has 46 chromosomes in it. Okay? Then it goes through the growth phase. And during that growth phase, you're going to double the chromosomes. So you're going to end up with 92 chromosomes. Okay? So by the time you get to the primary spermatocyte stage, you're going to have 92 chromosomes. See? Follow me? If you don't follow me with this, then you're going to end up with numbers that don't work out. So now you have 92 chromosomes. Now you split it. How many are in each of these? 46 each, right. 46 each. And then you take each of these and you divide them off, so you have 23, 23, 23, 23, 23 each. These are what we call the early spermatids. They just basically look like cells, regular cells. But then as they make their way down in a process called late spermatogenesis, they shed off the cytoplasm. You can see the cytoplasm is coming off here, leaving the genetic information, and they grow tails, and then they end up here as the spermatozoa, which we call the sperm. Now these sperm are ready to go. They're ready to embark on their mission, which is to swim through the female reproductive tract and fertilize an egg. So this is kind of what it looks like more accurately, more anatomically correct. So if it were. So here's that stem cell. It divides off. One stays here, one stays here. 46 chromosomes here, 46 chromosomes here. Then we have the replication of the chromosomes. So we have 92 here. Then that divides. We have 46, 46. Then we have 23, 23, 23, 23. And then they develop into the sperm. So this is all happening within the seminiferous tubule. Okay, that's where we are right here, the seminiferous tubule. Here's the outer wall of the seminiferous tubule. And then this is going to be the lumen, or that opening, and then the sperm will make their way from the seminiferous tubules through the straight tubules into the rete testes, then to the epididymis where they get stored. So it takes about 24 days for a sperm to develop into a fully functioning cell. But we also see that in order for this sperm development to happen, we have to have support from some hormones within the body. And we're going to see a very similar mechanism in the female reproductive system. It's just instead of the sperm that are developing, it's going to be the female's eggs that develop. So first of all, in the hypothalamus is going to release a hormone called gonadotropin releasing hormone, which is going to stimulate the anterior pituitary to produce two hormones, follicle stimulating hormone and luteinizing hormone. The follicle stimulating hormone is going to stimulate the development of the follicle or the reproductive cell. So the follicle stimulating hormone here is going to have an effect on the actual seminiferous tubules and the structures within. So it's going to be working on helping drive spermatogenesis. But the luteinizing hormone is going to target the interstitial cells that are outside of the seminiferous tubules, prompting them to secrete testosterone, which is going to have effects not only here in the testes, but also in other places in the body. So if you look at the bottom page 4, it talks about the mechanism and effects of testosterone activity. It can cause specific proteins to be synthesized, driving protein synthesis, which we'll talk about in advanced A&P. It targets accessory organs. It initiates the spermatogenesis, acts on the ducts, glands, and the penis, causing them to grow and assume adult size and function. But testosterone is also going to induce male secondary sex characteristics like the growth of pubic, axillary, and facial hair, deepening of the voice, thickening of the skin, increase in oil production, increase in bone and skeletal size and mass. And also increases the basal metabolic rate and masculinizes the brain. So testosterone is going to have an effect on the entire body. So when this mechanism becomes active and when the male starts producing luteinizing hormone and subsequently testosterone, that's going to lead to the sexual development of the male. So prior to, age 11, 12-ish, the body really isn't, their body isn't really secreting that luteinizing hormone. And then once they start secreting that, then they're going to be going through some body changes, and then you're going to notice those things. Same thing goes for the females, except it's not luteinizing hormone that leads to the production of testosterone. It's luteinizing hormone that leads to the production of estrogen and progesterone. And when that happens, then you'll see the female will start to develop her secondary sexual characteristics. And so this is where you start to see a larger differentiation between the male and female genders. All right, let's go ahead and take a break. come back in 10, and then we're going to jump into the female reproductive system. The anatomy of the female reproductive system is a little bit more involved, but we'll spend a little bit more time on the physiology of the female reproductive system because there's a little bit more involvement with that too. All right, so we'll take 10 and we'll come back and then we'll pick up from there.
Oh man, I really feel bad.
They're all over the place, right?
Mhm.
Yeah. Almost done, right? Almost done. Okay. All right, let's come on back and we're gonna talk about the female reproductive system now. And very similar to, oops, better bring the rest of us along here. Very similar to the male reproductive system. We've got a network of tubes, but the tubes aren't as extensive as they were in the male reproductive system. So this is just kind of a view of the female reproductive system at a glance. We find some homologous structures, and we talked about one of them already, but we have other homologous structures, which are structures that are anatomically similar between the male and the female. And one of those would be the ovary. The ovary is homologous to the testes. So if you think about what the testes were and what the testes were responsible for, it was the maturation, the development of the sperm cell. Well, now we look over here and we have the egg cells, and it's the maturation and development of the egg cell, or what we call the ovum, or the ova, referring to ovary. Now, there's a difference, though, between the males and the females as far as these structures, because, how would you say it? The males don't produce sperm until they reach sexual maturity, so until they reach puberty, and they'll continue to produce the sperm essentially on demand from that point on forward. For women, though, however, women are already born with all the eggs that they will ever have for the rest of their life. So when a woman is a fetus, she already has all the eggs that she will ever release from the ovaries and then some. So she already comes prepackaged with everything. So in essence, if you think about it, I don't know if this helps you at all to kind of wrap or to try to wrap your mind around this. If you think about it, half of your genetics is as old as your mother is. So you think about how old your mom is, and half of your genetics is the same age as your mom. Pretty wild, huh? And if you have any children, then half your child's genetics are just as old as you are if you're a female. Whereas the sperm are produced in real time. So what we're going to see as we look at the development of the egg is that you're going to have a bunch of them found in the ovary, but then one is going to be selected and then develop. And so we'll talk about that in the meiosis and all that stuff along with it. All right, so we have the ovaries found on either side of the uterus, which is this structure here. The uterus is a very important structure because it receives doesn't receive the sperm. The vagina receives the sperm, but the uterus is a passageway by which the sperm make their way toward the ovaries. But the uterus is also important because it's going to be the location of the implantation and development of the fetus. And then once the fetus is ready to be delivered, then the uterus is the organ of expulsion. So you'll see that the uterus has a very thick muscular wall called the myometrium, which we'll talk about in just a little bit. And so it's a big bag of muscles that contracts to push the baby out. So the uterus is a very, very important structure. So the ovaries are kind of anchored by different ligaments. And we see some of them here. We have an ovarian ligament, for example, that kind of anchors the ovary to the side of the uterus. The uterus is kind of held in place by its own round ligament of the uterus. So we've got some things that kind of keep everything in place and keep things from moving around. Just like the testes, we have a tunica albuginea, and then we have a germinal epithelium. Just to kind of put a cap on a summary of the female reproductive system, at the entrance to the uterus, there's an opening called the cervix, and then distal to the uterus and the cervix is the vaginal canal, which is the receptor site for the penis during intercourse, and this is where the sperm are ejaculated into. So now looking at the ovary a little bit closer, this is what we see here. We see, this is kind of like if you can imagine showing you everything at once. So like if I were to show you a snapshot of the sky, and you'd see the sun at several different points throughout the day, but you see it all in one picture. This is kind of what you're looking at here, okay? So this isn't what you necessarily would see in an ovary if you took a picture of an ovary. What they're showing you is everything that happens in the ovary, every stage kind of all at the same time. Does that make sense? I don't want you to get confused here. So we see the beginning and the end. So what we have, first of all, are these primary follicles. So these are the eggs, so to speak, that the female is born with. And the ovary is loaded with these. Well, what's going to happen is one of these eggs is going to be selected, and it's going to be coddled and cared for, and it's going to start to develop and get larger. And so what happens is it goes from a primary follicle to a secondary follicle, which we see here, and it keeps getting larger. Well, the egg itself really doesn't get, it gets a little bit larger, but the egg itself doesn't get all that much larger. It's everything surrounding the egg that gets larger. So then it becomes a vesicular or a Graafian follicle. But here's the oocyte. This is the prized possession right here in the middle, because that contains the genetic information. And then finally, when the hormone mix and the hormone concentration is just right, what's going to happen is this follicle is going to expel the oocyte, and that's a process we call ovulation. And so now we have the ovulated oocyte surrounded by a cluster of cells called the corona radiata. And when we jump into the reproductive system in advanced A&P, that's where we're going to start. We're going to start with the ovulated oocyte with the corona radiata that the sperm have to penetrate through. Okay, but that's a discussion for another time. So now we've got the remnants of this follicle that sticks around, and it's this structure right here, and it's called the corpus luteum. It's kind of like it's like I said, it's the remnant of that follicle, and it actually isn't done yet. It actually kind of beefs up and develops into a full-blown, well-developed corpus luteum. Now, this corpus luteum will stay there for a while, and then after some time, it will start to degenerate. And then what will be left behind is sort of like a little scar or a pit on the surface of the ovary where that ovulation took place. So every time a woman ovulates, there is a left behind scar or a pit that forms on the surface of the ovary. So throughout a woman's sexual prime or sexual lifetime, so to speak, when she is in her reproducing years, she's adding scars and little pits to her ovaries throughout the years. Now I'll just kind of jump ahead here, though it's not really what we're talking about in this class. We'll talk about it more in the next next time in advanced A&P, this corpus luteum is a very, very important structure. So let's fast forward. If this ovulated oocyte becomes fertilized, it needs to make its way to the uterus. But if the woman's body doesn't realize that fertilization took place, and if that fertilized egg doesn't implant into the side of the uterus, then the woman's going to enter the menstrual phase of her uterine cycle, which we'll talk about in a little bit, and she'll shut off that inner lining of the uterus, and everything will be lost. So the corpus luteum is important because the corpus luteum, as long as the corpus luteum is intact, the inner lining of the uterus will remain intact. So the two go hand in hand. And that's because the corpus luteum secretes estrogen and progesterone. And as long as there's the estrogen and progesterone present, the uterus will remain intact. If fertilization occurs, then we get a chemical signal through a hormone back to the corpus luteum and says, corpus luteum, you got to stick around because fertilization took place and we have an implanted embryo, now a fetus and it would be an embryo at that point. We have an implanted embryo in the uterus. You need to stick around. And so the corpus luteum will stay so that the woman doesn't enter the menstrual phase, so that she doesn't shed off an implanted embryo. However, if there's no feedback, if no implantation takes place, there's no feedback back to the corpus luteum. So if there's no feedback back to the corpus luteum, then it starts to degenerate. And once it starts to degenerate, the estrogen and progesterone levels fall, and those estrogen and progesterone levels falling is what initiates the menstrual phase of the uterine cycle, which we commonly say the woman will have her period then, at that point. All right? Second term is the term ovary. So what we see is that the ovary is not actually physically attached to the next part of the female reproductive tract, which is the uterine tube. The uterine tube has at its end these little finger-like projections called fimbriae, and they sort of welcome in the ovulated oocyte and kind of bring it into itself, and then that ovulated oocyte is going to make its way along the uterine tube. It makes its way about a third of the way down, and that's about the time that if the sperm are in the same area, that's about the place where fertilization will take place, about a third of the way down the uterine tube. But this has to take place within 24 to 48 hours after ovulation. If fertilization doesn't occur within 24 to 48 hours after ovulation, then things are not going to work out. So timing is very important here. If we look at the uterus, the innermost layer of the uterus is called the endometrium. And the endometrium is made up of basically two different regions. We have the more superficial region, which is called the stratum functionalis, and then we have the deeper region, which is called the stratum basalis. So the stratum basalis sits on top of the muscular layer, which is called the myometrium. And that stratum basalis is kind of always there. It's always there, same thickness. This is kind of like that base layer. It's made up of cells that continually produce more cells and more cells and more cells. Kind of like the stratum basal of the epidermis, if you think back to that. That's kind of like what the stratum basalis is. And then we have the stratum functionalis. The stratum functionalis is going to fluctuate. So it'll build up. It'll have all these well-developed vascular structures in here. We'll have uterine glands that supply and produce something called the uterine milk. It's really thick. It's really plush. This is a great, great, great environment for a fertilized egg, a zygote, soon to be an embryo to implant into. Okay, and that's the general idea. We want a nice, comfortable, hospitable environment for a zygote, which at this point is called a blastocyst. We want that blastocyst to be able to implant into the wall of the uterus and have a nice place to go. Okay? If fertilization doesn't occur, there's no blastocyst present, then what will happen is this entire layer here will be shed off. It'll just basically slough off, and then you'll be left with that base layer again. So the thickness of the wall of the endometrium will vary. So you can see the innermost layer of the uterus is called the endometrium, and then we have the middle layer, which is called the myometrium, and then we have the outer layer, kind of like the skin on the outside of the uterus, called the perimetrium. This is a picture of the external genitalia of the female. We have the what we call the perineum, which is a diamond-shaped area between the pubic symphysis and the anus here. You can see that we have what's called the vestibule, which is the area between these two thickened regions of skin here called the labia majora. In between that, we have the labia minora. So that's the vestibule between the labia minora. You can see that we have the urethral orifice. This is for urinary purposes, and then this is for reproductive purposes. This is the vaginal orifice. Sometimes we forget that the mammary glands are also a part of the reproductive system, because as the fertilized ovum, which then becomes the embryo, which then becomes the fetus, is developing within the mother, she also has to prepare to nourish that infant once it's born. So the mammary glands and their development is important in the development, important in that regard. And so very similar to what we saw in the testes, you have lobules made up of what would you call them? Alveoli, which then basically produce the milk, and then the milk make their way into the ducts, which then lead to the opening of the lactiferous ducts. So when she's nourishing the baby, then those lactiferous ducts are going to be bringing the milk to the baby. Okay, so we talked about the development of the follicle for the male reproductive system. Now we have to talk about the follicle. It was a sperm cell. Now we have to talk about the development of the oocyte in the female reproductive system, because it's a little bit different. So what you're seeing here on the left side is sort of a representation from a cell standpoint, like the number of chromosomes. Over here on the right side, you're going to see kind of a representation of what it actually kind of looks like in the woman's body. Okay, so here's the thing. We have a stem cell here, which has, let me just make sure I do my math correctly. Yeah, so we have a stem cell here, which is going to undergo mitosis, just like we did before. So we got 46 chromosomes in this cell here. And so what's going to happen is it's going to grow, and it's going to have actually 92 chromosomes in this structure here. And then once we get to that, then it kind of just stops. It's kind of like arrested. They call it arrested in prophase 1. It's just in suspended animation. It's not doing anything. So what's going to happen then is female's born, she goes through the first several years of her life until she reaches puberty. Then each ovarian cycle, which is about once a month, you're going to have one primary oocyte that decides to become coddled or cared for. So we see it develop from a primary follicle into a secondary follicle, into the Graafian follicle. Now, what's going to happen here is that we're going to have a surge in what we call luteinizing hormone. And when that happens, what's going to happen is we're going to discard what we call the first polar body. Remember, we have 92 chromosomes here. So what we're going to do is we're going to keep this nice large egg cell, but we're going to take the excess chromosomes, 46 chromosomes, and eject them. And that's called a polar body. It's just a small piece of genetic material that gets discarded. But we want to keep the nice big cell because we need all the cytoplasm we can, because when the sperm's chromosomes merge with the egg's chromosomes, they need a place to go. The sperm is basically just carrying the chromosome material. That's it. So then once we do that, now we have a nice big cell with 46 chromosomes, okay? So we got rid of the first polar body. All right? Now, that polar body here might divide off into 23 and 23, but that doesn't matter because the body is just going to, the polar bodies are just going to degenerate and be reabsorbed by the body. But you've got this 46 now, and so now what we need to do is we need to eliminate a second polar body of 23, so we're left with a nice big cell of 23 chromosomes. So in the female reproductive system, you're basically discarding 75% of the chromosomes and they have no useful purpose. Whereas in the male reproductive system, it's a matter of numbers. So the male will use all of the chromosomes present. It'll take all 4 sets of 23 chromosomes and turn them into 4 sperm cells, because it's about quantity and quality, but it's about quantity for the male reproductive system, because you basically have to blast the female reproductive system with as many sperm as you can to try to get to the egg. In a typical ejaculation, a male will release anywhere between 100 to 300 million sperm into the female reproductive tract. And of that 100 to 300 million, only 100 to 300 make it to the egg. So you need numbers as far as the male is concerned. So that's what happens. So you'll end up with one egg, the ovum, that has 23 chromosomes in it. But that second polar body does not get eliminated until the sperm merges with that cell. So once the sperm comes into contact with the ovum, now we'll get rid of that second polar body. So we're left with 23 chromosomes to merge with the 23 chromosomes of the sperm. So that's kind of just an overview of what's happening here. So just in review, we have what are called the primordial follicles here. Then one of them develops into the primary follicle, and then it gets larger and develops into the secondary follicle, then the late secondary follicle. Then it becomes the mature, the vesicular follicle. Then we have ovulation, where the follicle ruptures. And then we have the remnant corpus luteum here that remains. So when we take these events of the female reproductive cycle or what's happening with the egg or the follicle, we can put it on a calendar, and this is what we get. We get about 28 days, which we call the ovarian cycle. And right smack dab in the middle of it is ovulation. So prior to ovulation, we're developing the follicle. So that's called the follicular phase. And then after ovulation, we have the development and the presence of the corpus luteum. So that's why we call it the luteal phase. But we're going to stack this on top of what's going on in the uterus. And the two are going to work in concert with each other, hopefully, normally, to allow for the best chance possible for fertilization to occur, and also for implantation to occur, and also for reproduction to occur. So this is what's going on hormonally within the woman. We kind of talked about this for the male reproductive system. So the hypothalamus produces gonadotropin-releasing hormone, which is going to travel down to the anterior pituitary. Anterior pituitary is going to produce two hormones, follicle-stimulating hormone, which is going to help with the development of the follicle, luteinizing hormone, which is going to be responsible for the secretion of the estrogen and progesterone. When we get a surge of luteinizing hormone, that's when we eject the secondary oocyte, and then we have the corpus luteum, which is secreting the estrogen and progesterone. So you can see right at the point of ovulation, we have the luteinizing hormone and the follicle stimulating hormone that take a little bit of a spike. So there are some test kits available for parents that allow a woman to determine when it's a good time to try to get pregnant. I can't remember what they're called, but there are tests out there, and it's a long-term test. So after the woman has her period, she starts peeing in a little cup and then using a dipstick and putting the dipstick in the cup, testing the urine. And so what she's looking for are negatives to start with. So she's going to dip it in, and it's going to be a negative result, no change. And the next day, do the same thing, no change, no change, no change. But what's going to happen one day is that when she dips that little dipstick into the urine, it's going to be a positive result. This tells you now that there is a high level of hormone in the body. That luteinizing hormone is rising. So timing is good. This is when the parents want to try to get pregnant, because that's about the time that ovulation is going to occur. And remember, you have about 12, I'm sorry, yeah, it's not 24 to 40, yeah, it's 12 to 24 hours after ovulation in order for the fertilization to take place. You can also see that estrogen starts to ramp up about that time. Progesterone a little bit too, but you can see the effect of the corpus luteum here. You can see how the corpus luteum really helps with the elevation of these hormones, but you can see now when the corpus luteum starts to degenerate, and then we just see it all tail off. And when we start to see this tailing off of the hormone levels, this is when the woman's going to start to enter the menstrual phase of the uterine cycle. If we go to the uterus now and look at the thickness of the wall of that functional layer of the uterus, you can see that actually the beginning of the uterine phase is actually the menstrual phase. So at the beginning, for about the first 5 days, that's when the woman is going through the menstrual phase. After that, now things start to build up again. You can see the thickness of the functional layer starts to increase. So we have the proliferative phase. This is the growth phase. And then we have the phase beyond that. See, right after, this is where ovulation is, remember, at 14. So up until that point, the uterus is in its proliferative phase. But then after that's in the secretory phase. This is when the timing works out well, because it takes about 5 to 7 days after fertilization for the for the fertilized egg to make its way to implant into the uterus. Okay, so we have about 24 hours after ovulation. So at about day 15, that's when fertilization is going to occur. So we're looking at about day 20 to 22. Well, look where we are here at 20 to 22. Bam, right in the middle of the thickest stratum functionalis that we will have. All right. So that's like prime time for that implantation to occur. If implantation occurs, we send a chemical signal called HCG to the corpus luteum saying, I'm pregnant, you got to stick around. And so the corpus luteum will keep the functional layer nice and thick, just like this, until the placenta takes over with the hormones. So we'll keep the uterine lining. But if implantation does not occur, then what happens is the corpus luteum degenerates, and when it degenerates, now we see we're going to make our way toward the menstrual phase of the uterine cycle. So in your book, you should have them kind of overlaying each other. You should see them both at the same time. So your third term is the term uterine, as in uterine cycle. Okay, so just in case you're interested, we've got the hormones of the reproductive system, where they come from, what stimulates their release, what the effects are when they're exerted, and their effects on the organs, the metabolic effects, the neural effects, and so on and so forth. All right, so that's it for the female reproductive system. Now let's go to Learning Plan 15. Now, Learning Plan 15 is for a second I was going to have a minor stroke here because I was thinking, what are we talking about, the digestive system? But no, that's the last thing I talk about in advanced A&P. This is the urinary system. Okay, good. I'm glad I know what I'm covering now today. All right. So we're going to make our way over to the urinary system. The anatomy of the urinary system is very straightforward. It's even more straightforward than the reproductive systems that we just talked about. So where the real complicated stuff comes is in the physiology of the urinary system, talking about how the kidneys work, how the kidneys go about their processes of filtration and reabsorption and secretion. But we're not going to talk about that today. All we're talking about is essentially the anatomy of the urinary system and what's going on. I mean, what are the structures involved? So this is a very, very easy, very straightforward learning plan. Probably like the easiest one you'll have. Honest to goodness. All right, so here is the urinary system at a glance. So it all starts here with the kidneys. You can see that the right kidney is slightly lower than the left kidney. That's because we have the liver here. So we're competing for space. So in most of us, if not all of us, right kidney is just a little bit lower. The job of the kidney is to filter the blood, filter out the wastes. If we have full use of our kidneys, we can keep the metabolic wastes and other wastes of the body down to a manageable level that it doesn't kill us. So basically what we're trying to do is we're trying to keep the body from becoming toxic from all of the metabolic waste products that your body produces. Kidneys can deteriorate, and if they do, as long as you have two kidneys that are functioning above 80%, at or above 80%, you're okay. But if you ever fall below that 80%, that's when your body is going to start to have a very difficult time. And so you may see this in people that are just plain old, that they're doing fine, they're doing fine, they're doing fine, they're doing fine, and all of a sudden, just out of the blue, boom, they take a turn for the worse and they die. Because their kidneys are like teetering right around that 80% range. They're getting old, their kidneys aren't working so well anymore. And once they dip below that 80%, the body can't keep up. And basically what's going to happen is the body's waste are going to accumulate to the point where it's toxic and harmful to the body, deadly to the body. If a person has two bad kidneys, they have a couple of options. One option, which is the most common option because there just aren't a lot of kidneys laying around, is something called dialysis. And there's different kinds of dialysis that you can get. There's I can't remember what they're called, but one is essentially where you go once a week to a dialysis center, and but basically what they do is they will do the job of the kidney for you. They'll take the blood out, clean it, and then introduce it back to your body. So once a week you do this. So what's going to happen is the wastes are going to slowly build up. The kidneys are doing a little bit of the job, but not the complete job. The wastes are going to build up, and then you clean up, and then you kind of flush the system, and then you're good for another week. Thing is, once you're in dialysis, there's no going back. You're not going to get better. Kidneys aren't going to recover. Your kidneys aren't going to suddenly become better. So you never go back. It's a degenerative situation. You'll never recover from it. So once on dialysis, you'll always be on dialysis unless you end up with a kidney transplant, which is another option. There's another kind of dialysis that you can do from home, and I know this one for sure is called peritoneal dialysis. And what you do, the difference is you can do it from home, but you have to do it on a daily basis. So basically what you do is you have these, it looks almost like an IV bag, but it's a bag full of this like sugary fluid. And then you have a port that's implanted into your body, and then you basically flush out the system through the peritoneal cavity and kind of clean the body out that way. So the positive to this is that you don't have to go somewhere. The negative is you have to do it on a daily basis. Again, same thing. Once you're on dialysis, you're on dialysis, and there's no going back. And then the other option is a kidney transplant. So kidney transplant can work, can avoid dialysis. You can get off of dialysis if you get a kidney transplant. And what happens is the kidney will enlarge and be able to do the work of 80% of two healthy, normal kidneys. So as long as that one kidney you have is operating at peak function, you're good to go. All right, so those are some of the options, some of the things we consider. All right, let's take a look at the inside of the kidneys. Well, the kidneys are located behind the peritoneal cavity, as you can see here. And inside the kidney, we have some regions. We have an inner region, which is called the medulla. And the medulla is sort of sectioned into triangular areas called pyramids. And at the tip of each pyramid is called a papilla. External to the medulla is the outer cortex. So within the cortex and the medulla, we have the functional units of the kidneys called the nephrons. And the nephron's job is to essentially produce urine, which contains the waste. So the urine will be deposited into the areas just distal to the papilla, which is called the calyx, the minor calyx. So this is the minor calyx here. Here's the minor calyx, and then the calyces, the minor calyces, are going to dump into shared major calyces, and then the major calyces will merge to the renal pelvis, and then the renal pelvis will dump into the ureter, which will carry the urine from the kidney toward the bladder. Because we're filtering the blood, it's no surprise that we have an extensive blood supply throughout the kidneys. So we bring the blood into the kidney through the renal artery, and then we get the different branches until we get to the smallest branches, which are within the nephron, which we'll talk about the nephron more in advanced A&P, and then we make our way back out, and then the blood leaves the kidney through the renal vein. This is a nephron. The nephron is the functional unit that produces the urine, and the nephron starts here and ends here, okay? So the end result after the blood gets filtered through the nephron is that this filtrate here will make its way into what we call the collecting duct, and then this is where the urine goes. And this is where we spend a lot of time in advanced A&P. We talk about the nephron. We spend over a class period talking about the nephron and what goes on in here. There are two different types of nephrons. We have a cortical nephron. We have a juxtamedullary nephron. You can see how the juxtamedullary nephron has a very long tube, whereas the cortical is shorter. And we'll talk about the differences between the two in advanced A&P. But these are the functional units. This is what's doing the filtration, and this is what's producing the urine to eliminate the wastes from the body. So the nephron is where it's at. That's what we're really concerned with. So you can see that the blood enters the first part of the nephron through what we call an afferent arteriole. We filter out the blood here in this network of leaky capillaries called the glomerulus, and then whatever's left, the blood will leave through the efferent arteriole. And then whatever gets filtered from the blood is going to make its way into this tube here. That's a very brief, quick overview of what's going on in the kidneys. There are some things that you should not see in the urine. And you should not see them in the urine because all it's really supposed to be getting through and filtering through the filter mechanism of the kidneys is basically the metabolic wastes and the water. You should not see glucose in the urine. If you do, that means that there's more glucose than your body can handle. Because essentially what happens is the kidneys are responsible for capturing all the glucose that ends up in the urine and bringing it back into the body. Proteins, you should not see proteins. They're too large to get through the filtration membrane. If you see proteins, then there's some sort of disease process going on within or inflammatory process within the kidneys. Do not see ketone bodies because ketone bodies are usually only produced when your body is burning fats. So either you are consciously losing a lot of weight or you're diabetic if you have ketone bodies in your urine. You should not see red blood cells. You should not see bile pigments. You should not see, hemoglobin or red blood cells. And you should not see white blood cells in the urine either. Urine is sterile. If you ever see white blood cells or leukocytes, that's going to tell you that there's a urinary tract infection. The white blood cells are coming from the urinary tract itself. So the bladder, for example, would be where the white blood cells may be coming from. All right, so once we make it out of the kidneys, now the urine is going to flow inferiorly through the ureters. And the ureters are contractile structures. So if you remember us talking about the digestive, no, we talked about the digestive system. Get my classes mixed up here. So we talked about the digestive system. Remember we had the inner mucosa, then we had the muscular layer, and then we had the outer serosa. Well, here in the ureter, instead of the outer serosa, we have something called the adventitia. But otherwise, we have basically the same configuration as you saw in the intestines. So the idea here is that the ureters are not gravity dependent. So the ureters are engaged in peristaltic contractions. So if you were in outer space, or if you were standing on your head or upside down, the urine would still make its way from the kidneys to the bladder because of the peristaltic waves of the ureters. So once the urine gets through the ureters, they're going to enter actually through the bottom of the bladder into what we call through the ureteric orifices. And so the bladder is essentially going to fill up from the bottom up. Inside the bladder, we have rugae, just like we saw in the stomach, so the bladder can stretch, it can distend. Remember, we have that transitional epithelium in the bladder. There's also a muscular wall to the bladder, so that when the bladder needs to, it can contract to push the urine out of the bladder. This is called the detrusor muscle. I don't know if the drug is still out there, but there was a drug with a brand name called Detrol, which was designed to help people with overactive bladder. So you can see where they got the name from, right? It affects the detrusor muscle. So the detrusor muscle isn't contracting. Then, once the pressure reaches a certain threshold, now we're going to get a stimulus from the central nervous system saying, okay, it's time to eliminate the urine from the body. And so it'll make its way down through the bladder, neck. Now this is a male urethra, so it has to go through the prostate and then through the male urethra. So it's a little bit different what we see here, but we'll talk about what happens during micturition in just a little bit. So I compare this male urethra to the female urethra. So the male urethra, we see the length of the male urethra, and now we see the length of the female urethra. You can see the length of the female urethra is much shorter, which leaves women to be more susceptible to urinary tract infections because the bacteria don't have as far to move to get through the urethra into the bladder where it wants to be. The bladder is a great place for some bacteria. It's moist, dark, it's warm, great place to have a family, see? And so the bacteria can start to proliferate within the bladder. Cystitis or bladder infection. Now you'll notice that we have two muscles right here at the neck of the bladder. These are called the internal urethral sphincters. These are involuntarily controlled. This is controlled through the autonomic nervous system. Smooth muscle. So that means when it's time to urinate, the nervous system will tell these two, which are basically keeping the bottom of the bladder closed, you can relax. So the urine is going to start to make its way down through the urethra. But when we are potty trained, we are taught to recognize that sensation, that we're about to urinate. And if we're standing somewhere where it's not convenient or appropriate to urinate, we learn how to contract the external urethral, the external urethral sphincter, which then will close off the urethra. So we're basically holding it until we get to where we want to go to eliminate the urine. So the external urethral sphincter is skeletal muscle. So we can control that. Now, you can only do this for so long. You see this with kids who are younger kids who are potty trained or just getting potty trained or like to play and ignore their body's urges. eventually the pressure will be too significant for the external urethral sphincter to hold it back. So eventually, if you hold it for long enough, you're just going to end up peeing yourself, I guess you'd say, or peeing somewhere that you don't want. So it's not like years ago, and this is years and years ago, because I haven't watched The Simpsons. Are The Simpsons even on anymore on TV? I don't even watch that much TV. They're not on anymore? I don't know.
Reruns.
What's that?
The reruns.
Reruns? Okay. Well, anyway, there's an episode of The Simpsons where Homer's dad had to use the bathroom, and they kept telling him he couldn't use the bathroom, and so his kidneys exploded. Okay, that's not going to happen to you. So if you hold it long enough, you're just going to pee yourself eventually. So in your book, you have the control of micturition. So basically, urination. So it all starts here in the upper left-hand corner of your screen, where we have a certain amount of stretch on the urinary bladder wall because of the urine inside. So those stretch receptors send a signal to the brain saying, okay, the bladder is full. And so then the brain says, okay, well, got to get rid of it. So the micturition center then is going to have an effect on what we call the spinal efferents, the spinal cord, telling the spinal cord, okay, decrease the amount of control on the external urethral sphincter. We're going to decrease sympathetic and we're going to increase parasympathetic activity, which is going to activate the detrusor muscle and also relax the internal urethral sphincter. Now, we can say, okay, we don't want to urinate yet. We still have some conscious override, but if we're okay with everything, then micturition occurs. That's about it. So did you ever think, when you came to class the first day, the last thing we talk about is how you pee? Probably not, right? Okay, well, that's it. That's a capper. That's all we're covering in this class. So what you have left ahead of you is whatever you've got left for this class, whether it's finishing up some assignments from some older learning plans or exams, that final cumulative. That's about it.